If you're going to do nothing else, like focus on a great work environment for people, everything else will take care of itself. So as we think forward, I would predict that practice patterns are going to radically change over the next 2 to 5 years. At different paces at different organizations, but well-being undoubtedly is going to be part of the conversation because of what we've all been through together. So that makes me actually quite excited.
Welcome to Leading Quality, the podcast spotlighting the people moving healthcare forward from the front lines to the C-suite. I'm your host, Jason Meadows. Today's conversation sits at the intersection of three forces that are important in shaping healthcare right now: technology, clinician well-being, and the often invisible friction built into our daily workflows. My guests, Dr. Chris Dale and Dr. Ryan Dix, both of Providence, bring complementary lenses to this challenge. Chris is a pulmonary and critical care physician, former chief quality officer and chief medical officer, and now a leader working at the intersection of data, AI, and care delivery. Ryan is a psychologist and senior leader focused on workforce mental health and well-being across a large health system. Together, they've been studying something deceptively simple but deeply important. What happens when we design technology not just to improve efficiency, but to remove the small, cumulative burdens that clinicians experience every day? In this episode, we explore MedPearl, a clinical decision support tool designed to reduce referral friction, and the broader question it raises: should clinician well-being be treated as a core design requirement when we build and deploy new technology? This is a grounded, thoughtful conversation about systems, measurement, and what it really takes to make care better for both patients and the people delivering it. Dr. Chris Dale, Dr. Ryan Dix, welcome to the show.
Thanks for having us.
Yeah, thanks for inviting us on.
Well, we had one false start in the scheduling process. I'm looking forward to getting this conversation under our belts. And I did want to start maybe with just a 10,000-foot view of each of your backgrounds. Chris, maybe we'll start with you. I know you've had kind of an interesting path from ICU physician and then a variety of leadership roles, CQO being one of them, but not the current one. Maybe you can just give us an overview of your career.
Yeah, sure. Thanks, Jason. It's great to be with you. And Ryan, I always love hanging out with you. Yeah, I mean, I'm a simple country pulmonologist, basically. Like, I do pulmonary and critical care medicine here in the Seattle area, work at Swedish, which is part of the bigger Providence family. And then on the non-clinical side, I don't know, I've had a meandering journey. I started out as a flight surgeon in the U.S. Navy with the Marine Corps. And that got me interested in kind of aviation safety or the implementation of medicine. I think that aviation safety is kind of a gateway drug for a number of us into quality. And that led me to health services research, which led me to quality. And then I was a chief quality officer here at Swedish for a period of time, the CMO for a period of time. And then I kind of took a bit of a turn, and I've been trying to use data to improve quality. And that's what I've been really focused on for the last, 4 or 5 years. I've been the CMO of 2 different health data startups, and now I run my own kind of, with my wife actually, an AI company focused on small practices called Arborgenie. And then also work at Providence doing a variety of different health services research and other quality improvement sorts of projects. So yeah, I don't know, that's me in a nutshell.
That's great. And Ryan, how about for you?
Yeah, so I'm a psychologist by background. Have on the clinical side mostly spent my career in some form of hospital or primary care clinic, providing integrated primary care. So I had the pleasure of working alongside lots of physicians and APPs and a number of other care providers. I transitioned into leadership roles lots of years ago, and really since then, really kind of focused on overseeing clinics and a number of different programs. But over the last couple of years, had the opportunity to partner with a number of other parts of our organization to oversee all of the mental health and wellness initiatives for Providence. And that's been a part of my career, really for the better part of the last 10 or 15 years, at least in some form or fashion, focus on the well-being of all care providers and anyone associated with the clinical team. And so focused on that currently, and really enjoying being able to focus on the mental health and well-being of our workforce.
Great. And then, so if I'm understanding correctly, it is the workforce itself, so not as much about mental health initiatives for patient care specifically, but for the people providing care.
Yeah, so I'm on a team that has three pillars essentially, and so the pillar that I'm responsible for is the focused on employees or caregivers, and so our team does focus on patient initiatives, but that's not my role specifically. So my work is focused on caregivers specifically.
Yeah, and so with these kind of two very different backgrounds, I'm curious how you first came together to do work that we'll be talking about today, and how do these two lenses kind of complement each other.
Yeah, it's like how do you start a band? Actually, Ryan put a little poster on a lamp sign. It's like drummer needed, and I was like, "Hey, I play the drums," and that's how we got together. No, it actually started. I can maybe talk a little bit about the about the product that brought us together, and then maybe that kind of dovetails into the origin story for Ryan and I collaborating. Both Ryan and I work for Providence, which is a big healthcare system here on the West Coast of the U.S. 51 hospitals and n number of clinics. I don't even know how many physicians, APPs, nurses we employ, but it's a lot. It's big. One of my colleagues, a lady named Evie Cunningham, who now works at Cadence, had the idea. She's an OB/GYN doctor practicing clinically and doing leadership work. She had the idea that it would be very helpful if when patients came to their specialist, that the tests that they needed prior to referral to the specialist were kind of taken care of, and that the kind of the work that could be done in primary care was done in primary care, and that the patient's journey would be aided by making the referrals kind of right sized and at the appropriate time. And with that background, to her immense credit, with a gentleman, Adrian Yanis, spent their nights and weekends developing a tool that ended up being called MedPearl, like medicine, and then pearl because it was a little bit of wisdom. It was supposed to be pearls of wisdom, I think was the origin story for the name. And then they implemented that first in Teams, we're a Microsoft partner. And so we did a lot of we do a lot of Microsoft-based, I don't know how do you say it, like IS or back office sorts of things. So they built a prototype in Teams and debuted it with a small number of doctors, like a couple of, 2 dozen or so doctors and APPs, and got really high remarks or high grades in terms of the kind of the PDSA there was just based on improvement in the self-perceived quality of their referrals was the primary outcome measure there. And Evie and colleagues had some other ones. And then that thing done well, like I have this saying, like small things done well earn the right to do big things. Like that small proof of concept then led to the system wanting to scale it within the Providence Clinical Network, or PCN, kind of the physician APP medical practice arm of Providence. So then Evie and Adrian hired up some additional developers and built a tool working with content providers within the Providence family. So they try and find, Ryan's in behavioral health. So they try and find a friendly psychologist or psychiatrist to maybe, let's say, write a depression algorithm. And that would include both the diagnosis of the condition, kind of like yellow flags, red flags, like things to think about as you're seeing the patient in clinic, really focused on primary care and urgent care, and the ED as well. And then suggested tests. So if there are any kind of like imaging studies or lab studies that you'd want to do prior to referral, and then that would tee up then the kind of the next step in the patient's journey. And through the wizardry of Adrian's team, they were able to integrate in with Epic, and also through our Epic team, able to integrate into Epic, so it would pull contextual data about the patient from studies that they already had performed. So imagine if you saw information about the thing that you were looking up, kind of like an up-to-date or an open evidence sort of monograph in context with what we already knew about the patient. And again, like the whole premise here was to remove friction and help ease patients' way in terms of their care journey. So that was the tool that was developed. Evie invited me to join wearing my kind of like health services research hat or my technology assessment hat to understand the impacts of the tool in terms of practice. This is something that's been, I don't think widely discussed in our industry, but there's a lot of stuff around like AI or technologies in terms of like, hey, we got to measure it. Like we got to do stuff. We got to measure it. And there are precious few studies on the kind of the real world implementations of things. That coupled with just the tremendous financial pressures that organizations are on, I think people who innovate within the context of organizations have an obligation to serve the organizational mission. And part of that's being, fiscally responsible. It's, that saying in Catholic healthcare, no margin, no mission. That applies, I think, to innovation, and that our innovations need to show that they produce their intended effects. Otherwise, you just kind of go off in a billion different directions. And so Evie and I partnered then to do an analysis of MedPearl's intervention. And one of the main things that we kind of picked up, or she picked up at the beginning, Evie's the main driver. I'm just like some, random kid in the back seat. But one of the things that Evie picked up from the beginning was just this kind of like spark of feedback or this intuition that MedPearl eased people's way. There's so much happening in AI, like things are moving so quickly, and you can have this very kind of utopian view of things, this very dystopian view of the thing of the future, and it's hard to know necessarily for specific for the future what's actually going to happen. And so I think it's really for people who are interested in the space incumbent upon us to study stuff as things progress. And so the kind of the challenge that we laid down before us was to study the well-being implications of this MedPearl tool. Yeah, and so that's kind of what led to our partnership. We got extramural funding through the Physicians Foundation. There's a nonprofit in the States called the Physicians Foundation, but it's interested in aspects of physicianhood and physician practice, including well-being. And they put out an RFP specifically focused on kind of technology and AI and well-being, and then through the grant writing folks at Providence who responded to it. And then I was just like kind of shaken my professional tree with improv to find co-investigators who are working on the same thing. And I'd kind of heard of Ryan, but Ryan, I'd never met you before we started kind of collaborating on this. But there's a gentleman, Mark Rosenberg, who's done well-being work in the state of Oregon within Providence. And it was a mentor of mine from residency. And Mark knew Ryan and introduced us. And that's how we kind of jumped into the more formal assessment of the well-being aspects of this technology intervention. So I don't know. Ryan, I feel like I'm blathering on. What do you got to add? Subtract, clarify.
I think you captured it. I'm still wondering which part of the band I'm in though. If you're the drummer, but
What would you be? Do you think you'd be a? I could see you as a
I
singer,
don't know.
maybe.
Gosh, I hope not for everyone else's sake. But yeah, I don't know. No, I think you captured it well. I mean, I think that's at least as far as the origin story.
Ryan, I'm curious. So, your work, it sounds like, is primarily focused on clinician well-being, and so this is a beautiful intersection with the work that you're doing. When they come to you and say, "Hey, we'd like to assess this tool that we've created called MedPearl from the perspective of physician mental health from burnout," how do you start to conceptualize what that whole thing looks like?
Connecting with Chris was really first around what types of assessment around well-being would we want to look at? And there's lots of ways that you can assess well-being, whether it's a survey, whether it's impacts on lots of other metrics that exist. And so one of the things that we do within our organization is a survey that's provided annually for our physicians and APPs. And so identifying not only that tool, but how within that tool would we want to assess the impacts of really any intervention. And so MedPearl allowed us, one, to identify what the intervention was going to be, but then identifying whatever type of outcome we're going to really track as part of that. Within that, there's lots of questions in terms of what we know about the use of technology in the betterment of well-being. And it is a space that's evolving really quickly, but is a space that a lot of organizations have invested a lot of time and money into. And there are certainly some areas where it shows significant impacts, and there's other areas that it's maybe still a little bit up for question, either in terms of its impact more broadly speaking, or is it the same for all groups? And what we know from other studies is that some interventions work really well with some groups and some work less well with other groups. And so trying to identify, and so those were some of the additional questions that when you look at the broader well-being literature, I was able to bring into the conversation and have Chris and others' perspectives on as we think about the MedPearl tool. There's, of course, does it impact well-being, before and after, but then are there opportunities to further refine that, the utilization of that tool? And one of the things that I see as well is when you're thinking about an intervention, really deciding that there's, of all of the things that are available, which ones make sense for which groups. And I think that's some of the additional work that's being done in the well-being space is identifying maybe this can't be everyone needs this one specific tool, but are there specific groups within that? And so those are some of the additional parts of the MedPearl conversation that we were able to bring in.
It sounds like rather than maybe the way that well-being and burnout for healthcare providers is framed a lot of the time, which is in terms of things like reducing workload or building resilience at an individual level, I mean, this tool was conceived to kind of reduce micro frictions that exist within your system. And maybe I missed it, but I wonder if you can fill me in, Chris, on kind of where you said there was a small pilot that started and then they wanted to spread it. Where did it start? Kind of why did it, do you know why it started there? And then how did the spread look from there?
Yeah, well, that's a good question. And Ryan can talk about it, but he introduced me to the notion of pickle jar and pickle juice in terms of like, how do the paper cuts of daily practice impact individual physician or APPs or nurses, or even just extend it generically to healthcare workers. And so you're right that a large part of it is the brine, the juice that we're all immersed in. I think a whole thing, you'd have like a whole podcast, there probably are out there, on like innovation specifically within big systems. I think, that Paul Batalden quote of like every system's perfectly designed to get the results that it gets, like that applies to the big systems, which, Providence has been around for 150 years and has, very established ways of doing things. And so sometimes to push against that and to do things in different ways can be challenging, particularly in environments where there's a lot of financial pressure, because the organization really kind of sometimes can have a tendency to take a kind of a cost mentality and like, okay, what's the cost of this thing or that thing? And so to answer your question about like, well, where did MedPearl get started? Again, this comes back to Evie Cunningham. And I think that a lot of us who do innovation within bigger systems, it's, politics is described as the art of the possible. And I think that same label applies to innovation in big systems sometimes, is like, it's the art of the possible. If you're kind of mid-level person or a person with a good idea, it's like, what can you get done? What's within, like, what are the tools that you have available to you? Constraints can be very helpful from an innovation perspective. If you say like, hey, the rules of the road of this specific thing, I'm just going to talk generically, are we're not going to touch Epic. We're not going to play in the EMR and ask for like a new big module. We're not going to contract with like a new external vendor for a brand new service X, Y, or Z and going through the internal vetting, contracting, IS process, because that'd be a year or two anyway. We're going to say, given the tools that are available to us right this second that we can kind of get our hands on, what are the things that we can do in terms of improving, and then whatever the thing is that you're wanting to improve. So in this case, it was looking at I think Jason, you said it well, the kind of the micro frictions of the practice environment, with specifically knowing that a growth, and I just say this as like someone who's been practicing pulmonary critical care for, I don't know, whatever, 15 years now or whatever, is you accumulate knowledge about how to get things done in your system. And I think a little bit of the why that was starting, and Evie actually has pictures of it too, would be the doc who's been around for a while, or the APP who's been around for a while. She'd take pictures of their computer, their workstation, and they'd have like sticky notes about like, hey, if you're going to refer to cardiology, prior to that, like for AFib, like get an echo prior to referring or something like that. I don't know. I'm not a PCP, so that's probably a stupid example. But they had these sticky notes. And so Evie's like, well, there's all this tribal knowledge in there in everyone's sticky notes about like the way that patients actually flow through the system. And her insight was like, well, if we could capture that knowledge and we could say like, hey, dear OB, like, what do you want to see? Or dear GYN doctor, what do you want to see prior to the patient arriving at your door? It would not only be better for the receiving doctor, it'd be better for the sending doctor. And most importantly, it'd be better for the patient, because the patient, like sometimes there's like an extra step is like, you come and see me as a pulmonary doc and I'll just be like, well, I need a CT scan and PFTs. It's like, it's like a one neuron reflex for a pulmonary doc is like PFTs or CT, it's very easy for us. And so it's like, if the person shows up with all that stuff kind of already done, then it just eases people's way. And so it was really the art of the possible. So Evie designed this like literally nights and weekends. And she built it, like I said before, in as a Teams app, so that people could kind of select through it. And then she, using the power of persuasion, convinced, a dozen of her friends or 24 of her friends to try it in kind of the Southwest Washington area around Olympia, like our state capital, just south of Seattle. And she was thoughtful about it and did kind of before after surveys of people's self-perceived kind of, I don't know, quality of life. And I can't recall the different variables that she assessed in those surveys, but at the end of the day, she got this little bit of data that said, "Hey, there's probably something here." It was enough of a signal then to go to the leaders of the Providence Clinical Network, or the PCN, and kind of get the funding or the internal authorization to build it up bigger. So that's kind of how it started. Is just somebody's good idea. somebody using the constraints of their local environment to focus their thinking. Again, I think constraints, like you can view them as a negative thing, but they can also be viewed as a very positive thing because they can help focus innovation. And then small things done well earn the right to do big things. Like as someone who has dealt with healthcare data for 15 or 20 years now, I tell you, just like the start of things is just like count things. Like if you can count things, like it seems stupid, but just like tally stuff. And if you can tally things in one column versus another column, like you probably have a data set that like tells a story reasonably well. So don't overcomplicate it. And then that can be maybe the ember of the fires that you blow on to then earn the right to do something bigger.
Yeah, and Ryan, I wonder if this. So I can very much imagine, as a clinician myself, kind of thinking about someone referring to me. I really need something done. It's not done, and this is happening over and over and over again. And this is a real kind of maybe cognitive and emotional drag. Was this already kind of part of the work? Was this already on your radar that consults were a big point of difficulty for clinicians?
I think the broader theme that it taps into is what are a lot of those system components or environmental factors, and Chris provided that metaphor as he was responding. And so there's all of these things about systems that have significant impacts, sometimes small little bits at a time, but sometimes that's they're larger pieces that we know is really where well-being work should focus. There's a lot we can do, of course, in terms of teaching individuals more resiliency, but the literature really directs us towards focusing on organizational or environmental interventions more so. And so consults, being one part of those, but there's so many of those things, so many of those sticky notes on various people's computers about all of the little parts of systems that sometimes we adapt or kind of learn ways to adjust to it. But the reality is if we really want to impact well-being in the most substantive way, we have to focus on adjusting those pieces and not expecting Chris or any other physician to just continuously adapt. Of course they can, but that's really goes against what we know to be most effective when we impact people's well-being is what are those pieces that yes, you can and have adapted to, but boy, if we could address that and we could modify the system in a way that removed that from you, the amount of impact that can have on their well-being is markedly more significant than if we offer, any types of personal resilience stuff. Again, it's not to discount those parts, but we know that the vast majority should focus on that. So again, consults is an example of that, but there's so many of those things that are built into systems, particularly big systems, that can have a really significant impact on well-being. And so it's something that we are constantly focused on in terms of that well-being work.
One thing, Jason, I've wondered about that, just in terms of quality. I don't know if you have a comment on this one or the other, but like Ryan, you're talking there about like I think it was sometimes like the paper cuts, like just the difficulties of going through life and like the extra clicks. I wonder about it from the patient perspective too. Is all these clicks that it takes to get care and all the just kind of the steps and the hassle that all these things are going through. I mean, it seems like it's tremendously deleterious to the patient aspect of well-being, in addition to the the healthcare worker aspect of well-being. So I think that insight that Ryan has is just like focus on people's journeys and making the journey easier, if that applies more broadly.
I totally agree. And I think it's important even at a basic level that you're highlighting essentially that redesigning the work, like the nature of the work, how the work flows, how the dots connect, is such a big part of this, and not just insisting that people do things at an individual level to be more, quote unquote, be more resilient. Before we get into the details of, what you've measured and how you've measured it, I'm curious kind of how I guess how the sausage is made, or what is going into the MedPearl product itself. So how does it use, because now it's integrated with Epic, you said it's been deployed and it's been spread further. It's using real-time Epic data. It's using kind of semantic AI, maybe something akin to a large language model. Is that how it's working? How is it actually kind of taking in information and then making it useful to people?
Yeah, there's a bit of AI in terms of the search functionality of it, but the core of it is actually relatively although it's been historically very labor intensive, it's relatively simple kind of conceptually in terms of there's a large body of monographs or just kind of collections of writings on different topics within MedPearl. And so again, like the primary customer was conceptualized as primary care providers or urgent care providers, kind of bleeding into the ED space. And I should say too is that I'm like as kind of time has evolved, Providence is now spinning or has spun out MedPearl to a private company, and so a lot of these R&D works that Prov did to get it off the ground, like they've been transferred outside of our organization at this point in time, and so but historically, each one of those monographs then was hand labeled for the different fire resources or the different kind of cookie crumbs or the connectors into the EMR for the various kind of semantic objects that were necessary to populate the monograph. So, for example, if like let's say you have a one, I don't know, on GERD or question of upper GI bleed or something like that, you might link that to hemoglobin, and then we pulled all recent hemoglobin values or the 5 most recent hemoglobin values so that the provider in the context of the window, which was an iframe within Epic, would see their data the patient's data in terms of, hey, here's the most current hemoglobin is 9.6. The previous one was 10.2. The previous one before that was 11.5 or something like that. So I don't know. I'm choosing an inpatient example because that's where I work. But like similar sorts of things, like if you're training, I don't know, TSHs over time or something like that, or A1Cs over time, or other parameters you might be interested in for any one of those things. And so there was a collection of like hundreds or thousand different sorts of monographs that there were organizationally, there was kind of a senior person who was kind of in charge of the whole body of knowledge, and then different topic specialists, kind of like quarterbacks. And then they'd kind of farm out. And so like I would review some of the ones on pulmonary, like, hey, look at this one on, obstructive lung disease diagnosis or COPD management. And then the work there was concordance with guidelines and, and then they each had kind of like ticklers to come back to at a certain point in time to make sure that the evidence stayed up to date. But yeah, that's the process that Evie and Jessica Slitcher and others built to keep the kind of the knowledge graph of up to date the knowledge graph of MedPearl up to date. Up to date being a different product from Walter's
right. Exactly. Want to make that distinction very clear. And so in your collaboration and this work became focused on, how is this product, which already exists, which is already spread, I guess at this point, to all different types of consultations, like primary care consulting and urgent care consulting, every type of specialist at a couple of hospitals. Is that kind of where we are when you guys start to work together?
Yeah. So Evie and I started talking, a couple of years ago about it, and I knew about it. She was kind of to show me some demos of it, like very early on in the team sort of space. And I was the CMO of this kind of affiliated health data startup. So we were kind of crocking out over the data together and how to pull data and how to put data in context and what things. I've done some work on the more ML side of AI. And so we were talking about predictions and prediction engines and scores. There's some like, if you think about the things you can pull from Epic, there's some automatic scores that you can calculate. So that's part of it as well. I guess I didn't mention that. But anyway, but at that point in time, it was still in Teams. And then she got it implemented in Epic. Providence has 3 different, they're kind of like operated in parallel, but 3 physical different builds of Epic, just because Providence is so big. I don't know. I guess you can't have Epics over a certain size or something like that. I don't really know. But there's one in Alaska, there's one in Washington, Montana, and there's one in Oregon, California, or the 3 different builds. And so she got it put into each of the 3 different builds and was going through a kind of an internal change management sort of process, where she and the team were basically doing the dog and pony show, like, talking to anybody, any lunch meeting to tell people about it. And we had internal usage data. And I mean, actually from a QI perspective, it was fascinating that we produced some data where we were graphing the spread of MedPearl. And it was like, I don't know, it was like Jon Snow in the well or whatever. It was like you could see a hotspot emerge in a practice, and then it would spread to the usage would spread to the other people in the practice, and then it would seed like the practice down the road, and then that one would go or whatever. So you saw this like very geographic, very person centered, like, oh, how do how does behavior change? Well, it changes when you kind of bump into your friend at lunch or whatever, and they're like, "Hey, have you heard about this?" And then you're like, "No, like, how's it going for you?" And then through that conversation, then you begin to adopt it and stuff like that. And then we began to get profiles of like super users, like, these people that were in MedPearl, every patient every day, versus some more kind of like recreational users who would like touch it occasionally for maybe certain things, but not much. And then like people who basically never used it, never user sort of people. And they began to merge these like fingerprints. And the story I kind of told myself about them is that like the highest users are people who are relatively new to practice. They're kind of they tend to be sooner out of training, which kind of makes sense to me a little bit. Like you have this technology who's designed to aid people in their way in terms of like easing their way practicing. And by the time you get to be a little bit more established, you probably have certain ways, at least in your mind, about doing activities A, B, and C. And so it's like there's less utility in like someone coming along and telling you what you already know. So it tended to be people who are newer to the organization. It tended to be a little bit more. This was interesting. I wasn't expecting it. It tended to be a little bit more APP versus physician, and that was biased just the way our organization is organized. Urgent cares are kind of disproportionately staffed by APPs versus physicians, and so there's some hot spotting about APPs in urgent care. And that, like, if you're going to have like a single phenotype of the most common user, that would be it. Residents, similarly, there are a number of residencies that Prov's got. I don't know the total number, but half a dozen to a dozen different family practice and internal medicine residencies, in addition to other ones. But those would be ones where they would kind of take off, and like you'd see like basically the whole cohort using it. It was like this is how they practiced, sort of things. And so anyway, so that's kind of how it began to spread. Which I thought from like how do you understand user journeys? I think there are a couple of aspects of it that are really interesting to me as a quality improver is like one, just being able to map it out, because we were able to display the data just graphically. We did like this on the data nerd side, but we have a bunch of stuff in Snowflake, and we pulled it out and we like geocoded things for locations, and we created these maps that were really kind of cool and interactive. And you could see like changes in use over time based on geography, which I thought was just kind of interesting for us as we're trying to tell the story about like and trying to understand too. So part of that's on the like quality improvement data nerd side, and then part which is interrelated to quality improvement, but it's like, how do you build good products? And I think sometimes like I've done a fair amount of work over the years just in designing products, and that skill is maybe underappreciated, I would say, in traditional quality improvement, which tends to be, it comes from, Deming and industrial processes and things like that, not from a product design, like UI, UX sort of perspective. And I think that bleeding it over and saying, oh, like, how do I design an intervention where my users love to, be in the thing and they love to do stuff? And it's like, they get some kind of dopamine hit out of doing it. Like, that's a really cool design principle to have in terms of quality improvement. And so anyway, so we combined all those sorts of things, and that's how we kind of like told ourselves a story about who used MedPearl and its growth.
Yeah, I mean, a lot to dig into there. It sounds like, to use an example, essentially, how do you build Google search, or how do you build something that kind of has this inherent appeal to it? It kind of reduces friction in an obvious way. Is that kind of what you're getting at?
Yeah. I mean, I think that's a very good example. I mean, I think two things about it. Like one, like Google search is like, it doesn't come with a manual. Like none of us ever had to go to some sort of like web-based training to use Google search. So it is possible to design great products that are widely used without a lot of friction in the uptake process. And then the second thing is like, if you look at particularly in the earlier days of Google, just like its exponential growth, in terms of like, well, I mean, each of us could probably think back individually, like, and maybe we can't recall because it's so ubiquitous now, but like, how do we first hear about that thing called Google? And like, there was a bunch of stuff before, like, Lycos and web crawlers and Yahoo, and like Yahoo was like was the bee's knees, right? Like Yahoo was going to kill everyone back in the day. And then Google was this like upstart with like this like stupid looking homepage. It had nothing on it except for like the word Google. Like, what was that? Like Yahoo had all this stuff. And like now, like Yahoo, I don't even know. Like, I think it's around. And so like, I think that's interesting to think about is like, how can you get to something where the organic growth of it is just so compelling that it tells you that you're on to, I think it's like kind of the dominant solution is like the thing that has better outcomes for lower friction cost. Like, economics, a dominant thing is like better outcomes, lower cost. And you can think of that same thing sociologically or in terms of product development too.
So then as this is spreading, the two of you, find each other through this work and you get grant funding. And Ryan, I'm curious what kind of specific measures you started to put together so that you could be able to measure whether this tool was making an impact.
Well, as I mentioned a little while ago, we use an organizational assessment that allows us to assess well-being and so forth, that amongst a number of other things. And so those metrics had already been selected organizationally. And so from our perspective, it was really identifying which ones we felt like could be most useful in terms of asking the questions that we were looking to ask in terms of the use of MedPearl, and then really being able to extrapolate beyond that. And so I think, as Chris had pointed out earlier, just kind of trying to find what was already available rather than trying to add yet another survey or something like that. We know that there's a lot of exhaustion when we think about asking people additional pieces of information. And so that was the other part that was important to us, was really trying to identify, is there a data set that already exists in some kind of way that we might be able to tap into that would allow us to answer our questions.
Yeah. There's always an inherent risk in decreasing well-being by asking people too much how their well-being is going. So I'm curious if you're at the stage now of having some results that you can share, maybe on specific dimensions of clinician well-being, and maybe seeing areas where it's helping more or less. Are you kind of at that stage already?
I guess the short answer is probably no. So we're working with a PhD researcher who's been just absolutely wonderful, Amara Mahmoud, and she's leading in the project. And we have a couple of different research questions about. One is the association between well-being and product use, which we came into this with a kind of an association that people who had potentially greater indices of well-being, maybe greater self-efficacy, would be more likely to try to use the product. And then the second is that our hypothesis was that the product is associated with improvement in well-being over time, or greater rates of improvement in well-being over time. So those are the things that we're kind of like testing through the data right now. And we're at the stage where we have the data, we have it together, and we're analyzing it. So I guess, I don't know, the audience will have to stay tuned for the great reveal, but we're in the throes of analyzing the data at this point in time. But it's been really like a fun an interesting journey. And again, I'm deeply appreciative of the Physicians Foundation for the funding that makes it possible. And I do think that, I've done a lot of unfunded research work over the years. And as Ryan was saying, it's a bit kind of like catch as catch can in terms of the data. And I think that that's like a good health services researcher is like someone who's like, they kind of understand the data structure of their organization and like the stories that can be told from it. And then they kind of take advantage of things that are going to happen anyway. And then me and a colleague, Michael Meldal, used to joke that it's like our job is to put a p-value on it. Is like this, like natural experiments are going on all around us every day, and if we look with the right lens or we nudge things in the right way, we'll be lucky enough to put a p-value on it. And so, really, that's basically what this project is designed to do. And just excited as you are in terms of like seeing the end results of it. We have results on like the MedPearl, like the non-well-being aspects of MedPearl. Like there's a number of just like fascinating things about it. Like one, it's associated with a decreased referral. We were talking about referrals before, like that was one of the primary parts of it or whatever, but it's associated with the use of MedPearl is associated with decreased referral rates out of urgent care. And the story that we are, told ourselves there is that it kind of steered people away from having to like knee jerk refer if they understand, oh, I can order these tests, and maybe the person can follow up with their primary care provider, or the story can just kind of end there for their care journey, and they don't need a referral. Conversely, in primary care, it's actually associated with a very slightly but statistically significant higher rate of referrals. And I don't know, maybe the storyteller shows there's somewhat the opposite, is that it helps kind of refine people's thinking and then say, oh, these people should be referred. And then when people are referred, there are a number of interesting things. Like one, the organization was interested in kind of the business impacts of it, and the use of MedPearl is associated with improved surgical conversion rates and improved contribution margin on people who had conditions where MedPearl was used versus those same conditions where MedPearl wasn't used. And the story we kind of tell ourselves there is that, these might be patients for whom they're better kind of prepped for whatever might come downstream. And the organization might be able to and the patient might be able to get to the end result a little bit more efficiently. So there's just a bunch of very, rich data, like slightly improved RVU, decreased after hours charting time by an hour a month. Like there's just a bunch of like very interesting practice data about the tool.
Wow. Any hunches on which we don't have the data kind of fully assessed yet? Any hunches as to whether this is going to be, seen as a overall positive impact on primary care and urgent care physician well-being? Or is it just too early to say?
Yeah, I mean, I wouldn't be surprised if like the use of MedPearl is associated with well-being overall, like enhanced well-being overall, but maybe not like a tremendous amount. And I think that wouldn't surprise me just because it's very complicated. There's so many factors that go into it. The model of the environmental thing versus the personal things, and each one of those. And this is just like one very small aspect of the environment of care is how do you how do you smooth the referral process, or how do you smooth the caregiving process for patients in front of you? That's just like one very, very small slice of the pie. So it'd probably be illogical to think that it would have like a tremendous outsized effect on well-being overall. But I think I mean, what I think about those things is like it takes all of us. Like it's not going to be one thing. It's going to be a bunch of things. And so like we gotta like our for people who care about healthcare delivery and care about patients and care about healthcare workers is what are the changes that we can make in terms of the whole care production pipeline to decrease all sorts of different frictions. And then how can we know those things? And that like putting a p-value onto the scientific process, like that's what I take maybe most away from quality improvement overall is just like having a hypothesis and measuring the outcome of it. Like that process there, that's the thing that really ends up winning the war is, individual like kind of hypotheses we have from time to time may or may not be right. Like that's the whole point of having them. But the overall approach is one that really tremendously has legs.
Having had this experience, and I think so often, if we're talking about a new tool or a new care pathway or something, then like so often we're talking about increasing some kind of efficiency, right? Decreasing a wait time or increasing some kind of, bed turnover rate or whatever it might be. But this is, using the data you already have, this is very focused in on clinician well-being as a result of this tool. Should clinician well-being be kind of treated as a formal design requirement by healthcare institutions before deploying new technology? Should this be, or is this something that is kind of routinely a lens through which your organization or organizations that you've seen generally view new technology?
Yes, it should be required. And just to elaborate on that a little bit, I mean, the data, at least from my perspective, is pretty clear of the impact of the well-being of our physicians, APPs, nurses, medical assistants, all that has impacts on every data point you could possibly care about, whether you're a clinician, whether you're a healthcare administrator, whether you're a patient, whether you're a patient family member. And so it of course we care about the person experiencing, well-being or absence of well-being. But when you look at all of those downstream impacts, to me, the picture is very clear that should be an absolute requirement of really any new technology that we look to implement. I think the questions then become which technologies for which groups, and that's where I think organizations hopefully are. I feel like the conversations have progressed a little bit from where I started, whereas initially well-being I think was seen as a nice to have, or like as a not at Providence specifically, but just kind of more nationally. Part of the conversation wasn't really recognized for the level of importance. And I think for better or worse, one of the things that the pandemic kind of shined a light on was a lot of the importance of well-being on the healthcare workforce. And so I feel like the conversations have progressed a little bit past, although they still happen in certain places, the need for it, but it's now kind of what's most efficacious, and beyond that, which groups would most likely benefit from, X tool or Y tool. And I think that's where the literature is hopefully moving toward, is being able to allow us to more specifically articulate those groups that would most benefit from something like MedPearl or another piece of technology.
Yeah.
I do wonder a bit about that though, Jason, because like you posited before, like the the off-cited survey fatigue is like, oh yeah, like the we don't like people don't really want to be like surveyed all the time about various things. And I've always kind of wondered the kind of the counter of that, which is like, Ryan, if what you're saying is true, that we need to, and I like 100 million% agree with this, is that like, if you think about the quadruple aim, like the people are the fourth part of the quadruple aim. Like there is no organization without the people. Like if you're going to do nothing else, like focus on a great work environment for people, everything else will take care of itself. Like if you just wanted to have that as an organizing principle, like that is a recipe for a successful organization. So if that's true, then like other than kind of like asking or measuring, like in some ways, and maybe I'm answering my own question, is like, how do we get at that part of it? Because I feel like if we just kind of like, cut ourselves off at the knees and we're like, oh, well, people don't want to be asked about well-being, like, therefore we can only ask, once a year on a structured sort of thing. And then the countervailing point though is like, well, all of our interventions need to have a well-being component to their assessment. It's like, well, what's the instrument then? Like, how do you like, I'm a simple person. Like, just tell me how we're going to measure it, And so it's like, I just kind of wonder about that. Is like, do we use indirect measurements? Like, pajama time is one that is like sometimes cited for EMR things, or like, how do we get at well-being, like outside of these like very formal, it seems like almost too formal, too rigid, like annual surveys? Like, who's doing it the best?
Yeah, I think we need to look at additional ways to identify the impacts of whatever interventions we apply. And surveys serve an important role for a number of different reasons. But I think to your point, one, we know that those that are most burnt out are least likely to actually fill out a survey. And most likely, if they do fill it out, they're pretty far kind of down the path of burnout, and so there may be limited interventions that are available for that particular person. And so I think really focusing on what are those other ways that we can ascertain that information that not only informs what interventions we're going to apply, but what was the ROI on those interventions in terms of the well-being for that individual. And again, I think that the literature provides a number of different outcome measures that we can look at that give us that information, that again, large healthcare organizations oftentimes have that data and collect that data just as part of their normal daily functioning. And so I think that's another area where organizations are moving some of their well-being work, is being able to identify what are some of those other markers that we can utilize to supplement or perhaps more accurately inform some of the work that we're doing.
Yeah, I guess some of my own curiosities about how you would, like stagger surveys throughout the year, or have some kind of like, in-person interview components to assessing people, or sampling small samples of people that, around the organization, to see kind of how well-being is evolving over time. But I'd be so curious to know kind of what the future looks like when once you're there. Maybe Ryan, you can let me know in terms of the in terms of how you ultimately decide to measure that. I am conscious of time, since Ryan, I know yours is limited. We're running towards the end of your time window here, but I did want to just get your take, fast forwarding a few years, if this work has really achieved kind of its highest aspirations. How are things different maybe for primary care and urgent care clinicians at Providence?
Hopefully it has at least some positive impact. Again, I don't know that it by itself would be the kind of one solution for all challenges, but I would hope that it would be part of that solution that really brings them to a place that restores the joy in medicine and restores that joy in practice. And I think those are the parts that any type of well-being work, that's what we hope for, is that, even if in a small way, it provides some positive impact. And so I think with this work, I would say the same.
Yeah. If there was a place that you could lower friction, so a next area of focus after the consult workflow, is there a next place you would choose to start lowering friction after this work is complete?
Yeah, I mean, I totally agree with what Ryan said, just in terms of this shines a light on the importance of well-being. But I'd go even further and say that, like, it's what's that saying, like sometimes attributed to Berwick, is like, the future is here, it's just not evenly distributed. Like, the best care in the world is somewhere, it's just not everywhere. And that's what I think the issue of the next 2 to 5 years is going to be. Like, information technologies are changing at such an incredibly fast pace I'm very thankful in retrospect for the fact that the pandemic happened, specifically with the focus that I think it had and the enlightenment that it had in terms of the importance of well-being. Like the well-being conversation, I think from my limited perspective as an ICU doc specifically, like changed materially by virtue of going through this pandemic together. And the importance of like Ryan's activities and well-being, we're not going to erase it. We're not going to go back on that. And so as we think forward, like I would predict that the practice patterns are going to radically change over the next, 2 to 5 years. Different places, different paces at different organizations, but well-being undoubtedly is going to be part of the conversation because of the work of folks like Ryan and because of the fact of what we've all been through together. So that makes me actually quite excited.
That's a great place to round out the conversation, respecting time limits that we have today. And I think there's so much more we could dive into here, honestly. I always find I bite off more than I can chew with these topics. But for listeners who would like to follow each of you and connect with you or follow your work more closely, what's the best way to do it? Maybe Ryan, I'll start with you.
I think the best way would be through the Wellbeing Trust website. You're able to see my information there as well as a lot of the other great work that the Wellbeing Trust does for Providence.
Yeah, and for me, you can find me at Snoqualmie on X or Twitter, and then arborgenie.com.
Very good. Well, thanks so much again. Really appreciate your time for the conversation. I'm grateful for the rigor that you're bringing to this work, and I'm excited to see where MedPearl goes and how you can improve clinician well-being. Thanks so much, guys.
Thanks for having us.
Thanks, Jason.
Thanks so much for listening to today's episode of Leading Quality. If you enjoyed the show, please take a moment to like, subscribe, and share it with someone who might find it useful. You can find all our episodes at leadingquality.buzzsprout.com or in your favorite podcast app. The show was written and hosted by me, Jason Meadows, edited by Milan Milosavljevic, and produced by Thrive Healthcare Improvement. See you next time.